Thank you very much for inviting me to contribute for this meeting. I'd like also to thank Biologix for sponsoring the symposium. I was given the task of explaining or talking to you about lysosomal acid lipase deficiency, or LALD, which is one of the hidden causes of dyslipidemia and liver dysfunction. And I'll start with a case presentation about a 13-year-old child who was referred for a routine check because of delayed puberty. He was the first son of consanguineous parents who had no significant family history of note, and on systemic review, the child was fine, apart from slightly overweight with a BMI of 26, but his height was fine. He has no acanthosis nigricans, slightly pale, but has no jaundice. And in fact, he had evidence of early puberty, which was reassuring for the parents. Further assessment, his liver was 4 centimeters below the right costal margin, and his spleen was not palpable. His hemoglobin was low at 9.6, and his ALT, or liver enzymes in JAMA, ALT, AST, and gamma GT were a little bit higher than the normal. His alkaline phosphatase and bilirubin were normal, and he had negative hepatitis serology as well as autoantibodies. And further assessment to identify the cause of his deranged liver enzyme revealed normal copper, phthalate and alpha-1 antitrypsin. Lipid enzymes or lipid profile showed a high total cholesterol of 7 millimole, as well as a high LDL cholesterol and triglyceride, but his HDL was low. His abdominal ultrasound confirmed that he has hepatosplenomegaly, of course, and his spleen was just measurable, and that's just mildly enlarged, and that's why it wasn't detected in the examination. He had a grade 1 to 2 hepatosteatosis, and the diagnosis or the possibility of non-alcoholic fatty acid or non-alcoholic fatty liver disease was made, and therefore he was given iron to treat his mild anemia and was asked to change his lifestyle slightly. And indeed, in 9 months' time, he came to the clinic, progressed in puberty. His BMI improved from 26 to 24, but still has hepatosplenomegaly, and his liver enzyme as well as liver lipid profile remained the same, and his ultrasound confirmed or showed an advanced stage of hepatosteatosis. And liver enzyme was conducted at that time and showed microvesicular steatosis, minimal lobular inflammation, as well as stage 3 to 4 fibrosis. And at this stage, the diagnosis of NAFLD was questioned, and the differential diagnosis was widened to include LALD, and his liver or his LALD enzyme activity was measured and was low. This low enzyme was confirmed by Lipase mutation, confirming the diagnosis of LALD. More interestingly is that further family screening revealed an unaffected 4-year-old girl who was completely asymptomatic. So this condition is one of the lipid storage disorder characterized by marked lysosomal accumulation of cholesterol ester and triglyceride due to LAL enzyme deficiency. It is a rare condition, estimated prevalence ranging from 1 in 40,000 to 1 in 300,000. It's caused by recessive mutation of the Lipase gene, which encodes for the LAL enzyme, and so far more than 100 mutations leading to either little or no enzyme activity were identified. This enzyme meant to hydrolyze the cholesterol ester and triglyceride from the LDL cholesterol to free cholesterol and fatty acids, which are important for further lipid metabolism. Now, so if you have mutation here, you miss the enzyme, you lead to accumulation of the CE and triglyceride in multiple organs, mostly the liver, which manifests as hepatomegaly, and raised liver enzyme characterized by the ALT and AST leads to steatosis, fibrosis, portal hypertension, and liver failure. And the heart is also affected with dyslipidemia, characteristically with high LDL cholesterol and low HDL, leading to accelerated atherosclerosis, stroke, coronary heart disease, and myocardial infarction. It can also accumulate in the spleen, leading to splenomegaly, which consequently lead to hypersplenism characterized by anemia thrombocytopenia, and can also lead to traumatic rupture or need splenectomy. It can also, the lipid also can also accumulate in the intestine, leading to abdominal pain and malabsorption and leading to growth failure. Can also affect the adrenal as well as the kidney, leading to adrenal calcification and accumulation of the lipid in the kidney, which can be detected as adrenal calcification in the X-ray. So this condition has two forms based on the residual enzyme activity. There is the childhood adult form, which usually present late and historically called cholesterol storage disease. And although it is late onset, but it can progress very rapidly to significant liver cirrhosis and coronary heart disease, and they will have all the characteristic or most of the characteristic features which I mentioned in the previous slide. There's also the infantile form, which is historically known as Wolman disease, which is a rapidly progressive condition, can present at birth and leads to premature death. And characteristically, these patients, they have adrenal calcification in the X-ray. It is very rapidly progressive condition, regardless of the timing of the presentation, and the consequences are very devastating, and therefore the diagnosis is really very essential because there is a treatment now available. And making the diagnosis at the look is simple, but I think you really need to dig further to reach this diagnosis. Now, you can consider it in the clinical suspicion in any infant with jaundice, unexplained hepatosplenomegaly, or liver failure and failure to thrive, or anybody with dyslipidemia with high liver enzyme, regardless of the age, particularly if they have a low BMI, or particularly if they are not obese, and also patients who are raised as metabolic syndrome, NAFLD, but continue to have persistent ALT elevation after significant weight loss, as they're similar to the child I showed you at the beginning, or if you have somebody with early onset coronary heart disease with hepatosplenomegaly, or if you have somebody with what we call idiopathic or cryptogenic liver cirrhosis, or if you have any concern about lysosomal enzyme. The biochemical confirmation is easy, and measuring the enzyme activity nowadays can be done in dried blood spot compared to the past where cultural fibroblasts or peripheral blood cells were used. Liver enzyme and imaging can be helpful, but we try to avoid using them, and the genetic diagnosis or confirming the diagnosis with genetic testing is now available, either by directly sequencing the Lipase gene, which caused the condition, or the mutation in that gene caused the condition, or using either targeted lipid gene panel or whole exome sequencing. But despite that, there is often a delay in making the diagnosis, particularly in children and adolescents. And there are multiple reasons for that. There's a lack of specific clinical finding. There is a broad spectrum of disease presentation, and there's also significant overlap with more common disease, particularly common causes of hyperlipidemia. And if you look here at the LAL biochemistry or the LAL clinical presentation in general, I mean, there are a lot of overlap with more common causes of dyslipidemia, such as the heterozygous familial hypercholesterolemia, familial combined hypercholesterolemia or hyperlipidemia, NAFLD, NASH, and metabolic syndrome. And I think the most characteristic thing here is the persistently high liver enzyme, despite whatever you do, and hepatosplenomegaly. The weight is usually normal or slightly low in LALD compared to other forms of hyperlipidemia, such as NAFLD, NASH, and as well as maybe metabolic syndrome. But so it's very important really to look at patients in your cohort or in your clinic with these conditions and try to find out whether you might be missing something, particularly if they have very high raised liver enzymes. This is a data from a very nice study and looking into the LALD among a large cohort of patients with familial hypercholesterolemia, heterozygous familial hypercholesterolemia, and other forms of dyslipidemia. And that's including adult and children. It's nearly 700 patients who who are mutation negative for familial hypercholesterolemia. And what they did, they just looked at, they sequenced their Lipase gene in all these patients who are mutant negative familial. And nowadays, the genetic testing is not that expensive. And out of the 700, they identified 4 children with LAL-D within the group or within the cohort of the familial hyper or the heterozygous familial hypercholesterolemia. And these patients, interestingly, they all have mild liver function at the time of the diagnosis of familial hypercholesterolemia, but they were not considering to have LAL-D. And this is just an example of how this condition can be easily overlooked, particularly if you have some heterozygous family members who also have this lipidemia. And the conclusion of this study, or the message we got from this study, is that patients with familial hypercholesterolemia should be investigated to identify possible LAL-D patients who need completely different treatment compared to the familial hypercholesterolemia. And this is, of course, we mean the patients who have no genetic confirmation of familial hypercholesterolemia, and those who have mild liver dysfunction or mild raised liver enzyme. Another case reports, this time in pediatrics, were identifying 2 children who were raised as NAFLD and achieved very good weight reduction, but failed to have the anticipated improvement in their aminotransferase and gamma GT. And the liver enzyme confirmed that these patients have microsteatosis, LAL activity was low, and the Lipase sequencing confirmed the diagnosis of LAL-D. And the conclusion of this study was that LAL-D should be considered when the fatty liver indices or when the liver indices in patients with NAFLD failed to improve despite appropriate weight reduction, similar to the patient I showed you in the first patient I showed you in my presentation. Management of this condition is multidisciplinary, like any multi-organ condition. Very important to have a general pediatrician or physician orchestrating the link between the other people, like the endocrinologist, gastroenterologist, cardiologist, and more important is the dietitian. Different treatments being tried in the past. Low-fat diet is good, but there's an issue with the compliance. Statins showed some improvement of dyslipidemia, but there was a concern that it might accelerate the liver disease. Stem cell transplantation worked in some infants, but fatal transplant-related complications happened in others, and liver transplant, the same applies for liver transplantation. And I think the main issue with all the conventional or maybe the historical treatment is the limited, is that they don't really address the underlying pathophysiology of the condition. This study looked at using recombinant human lysosomal acid lipase called cell lipase alpha. And as you can see, it's a multi-center, double-blinded, randomized controlled trial, 36 patients given cell lipase alpha, 30 placebo, including adult and children. Primary endpoint, normalization of the ALT level, secondary endpoint, change in the lipid profile, as well as the fat content, as well as the fatty acid or the safety side effect profile. And as you can see here, the remarkable improvement in the ALT in the cell lipase arm compared to the placebo. And this has led to opening the trial after 20 months. So even those who were in the placebo were given the cell lipase, and the same applies for the low density lipoprotein, dropping down nicely, associated with rise in the high density lipoprotein. So it works nicely in the lipid as well as the liver enzyme, particularly the ALT. Now, what about the liver content? It's the same. The liver fat content is the same improvement, reduction in the treatment group compared to the placebo, and the same applies to the change in the steatosis based on the ultrasound finding. And more importantly, there was no significant adverse effect in the treatment group or the cell lipase alpha arm compared to the placebo. So the conclusion of this study is that the cell lipase alpha is well tolerated and significantly reduce the hepatic as well as the lipid abnormality in children and adults with these conditions. And as a result, it has been approved in the USA, European Union, as well as Japan immediately after this study. More importantly, or more interestingly, is that the survival in infant has improved dramatically after using this enzyme replacement. And the further studies in children and adults confirmed the same thing. And I think this is my penultimate slide, and I'd like to just alert you for this nice consensus which came out a few just before or just at the beginning of the COVID crisis, and it summarized the initial assessment, ongoing monitoring of patients with lysosomal acid lipase deficiency in children and adults. It contains very nice tables and algorithms which can help anybody to manage these patients properly. So in conclusion, LALD is rare, but could be overlooked as the features can overlap with more common conditions. I'd like you to consider it in any individuals with dyslipidemia and high liver enzyme, i.e. the combination of both things. Early diagnosis is very important to avoid devastating consequences, and LAL activity can be measured using dried blood spot, and genetic testing are now available to confirm the diagnosis. And more importantly, there is a specific treatment now for this condition, which showed to be effective and well tolerated both in children as well as in adults with LALD. With this, I'd like to thank you all for your attention.